Hello, everyone, and thank you for joining us today. I'm Mike Clayville, Vice President of Worldwide Commercial Sales and Business Development at Amazon Web Services. But I'm here today not only representing Amazon, but also the trustees of the Fred Hutchinson Cancer Research Center. I also happen to be a board member of our own Amazon Care Group and a staunch supporter of health research worldwide. Today, we are lucky enough to have a world-renowned set of experts in infectious disease and cancer research from our partner, our local Seattle neighbor, Fred Hutchinson Cancer Research Center. You know, Amazon and the Fred Hutch have been doing a lot together for many years now, and it's had a real impact. I'll just give you a couple of examples. You know, AWS and the Fred Hutch teamed together to bring to market something that we call Medical Comprehend, which is helping the Fred Hutch identify patients that could be recommended for really critical life-saving clinical trials. We're also currently working on something called the COVID Watch that aims to find a vaccine for COVID-19. So a lot going on, and I've been delighted to be associated with the Fred Hutch for the last 4 years as a trustee. And what I love about it is they share a lot of the same values as Amazon. That notion of innovation. The Fred Hutch is arguably one of the most innovative cancer research centers in the country. They were famous for inventing bone marrow transplants 30 years ago that's had a real impact on leukemia patients. And they've also been really the forefront of immunotherapies, which is having a real impact on cancers of all types. And it's my pleasure to bring the program to you today, and I'll start by introducing our guests before we get into the Q&A. Let me first introduce Dr. Tom Lynch. Tom's the president and director of the Fred Hutchinson Cancer Research Center and holder of the Rasbeck Endowed Chair. Prior to joining Hutch, Tom was in leadership positions at Yale Cancer Center, Mass General, Bristol Myers Squibb, and a professor at medical schools of both Harvard and Yale. His first day at the Hutch was February 1st, and I think we all know what happened after that. You know, one of the first things Tom and his leadership team, as well as the board, had to do is work closely to safeguard their vital cancer research, protect their staff, patients, and our community. And by the way, they had to quickly launch a bunch of research around COVID-19. Under Tom's leadership, the Fred Hutch has been at the center of the successful public and private effort to flatten the curve of transmission of COVID-19 in our cities, our state, and across the nation. We're also delighted to have Dr. Trevor Bedford. Trevor is an evolutionary computational biologist who founded a website called nextstrain.org. It tracks epidemics in real time around the world, including things like Ebola, influenza, and now COVID-19. Trevor sequenced the first COVID-19 case that showed the virus was circulating in the Seattle area. It was the first locally transmitted case detected in the United States. Since then, he's been at the forefront of tracking COVID-19 spread around the world. His research and his explanations on Twitter have earned him more than 25,000 followers, and I've been one of them and really enjoyed reading the tweets and understanding more about COVID-19. We also have Julie Overbaugh. Julie's a virologist that's been studying the interaction between viruses and the immune system for 35 years. She was recently elected to the American Academy of Sciences, Arts and Sciences, for her work in studying HIV transmission in vulnerable people, including commercial sex workers and infants born to mothers with HIV. She's turned all of that expertise now towards studying COVID-19. And finally, we've got Dr. Steve Peregrym. Steve is an infectious disease researcher at the Fred Hutch and the medical director of infectious prevention at Cancer Care Alliance. He plays a critical role in advising policymakers in ways to protect patients, our caregivers, and our community from COVID-19. In fact, the Seattle Times calls him mismanners of social distancing. He's the guy you go to if you have a question about how to stay safe from COVID-19, and I know we all have many of them. So thank you all for being here. It's a delight to have you. We're so excited for this Q&A, and we're looking forward to hearing about your work and getting some of our answers to our questions. We've had a bunch of questions across the entire Amazon employees send in, and let's get started. I'm going to kick it off with a question to you, Tom, and then I'll ask you to take it from there. Tom, you were faced with a pandemic within weeks of assuming leadership of the Hutch. You had to get to work quickly to protect Fred Hutch as an institution, and at the same time, the Hutch scientists were jumping into research on COVID-19. What's it been like to lead the Hutch through this very difficult time, and why is a cancer center so heavily invested in infectious disease?
So Mike, thank you for the question, and thanks so much for having us today. The relationship with Amazon has been incredibly important to the Hutch, and many of your employees and the company itself has supported so much of what we do at the Hutch. So I'm about 4 months into my leadership of the Hutch, and I don't think anyone could have imagined that we'd be facing a global pandemic, a worldwide recession, and then perhaps most profoundly, a moment of reckoning in terms of racial justice and confronting racism as a society all at once. I'll talk about the first one, which is the global pandemic. The Hutch has always had an incredible interest in viruses. So you might say, why? Two major reasons. One, we think about 1/3 of cancers around the world you can trace to a given virus. Some examples: Hodgkin's disease is caused by a virus. There's certain types of cancers of the head and neck that are caused by viruses. Cervical cancer in women is caused by a virus. Kaposi sarcoma is caused by a virus. So this relationship between viruses and cancer is pretty clear. And so if we want to reduce global cancer burden, reducing viral burden also helps. Second thing is, for patients who've got viruses, cancer has become a leading cause of death. And Julie Overball, who'll be with us today, is an expert in HIV. And if you look at people who have HIV, one of the leading causes of death for people with HIV is cancer. So at the Hutch, we've always had about 25% of our research has been in virology. So when the pandemic hit, the Hutch was very well positioned. We had all these people working in HIV, working in human papillomavirus, working in hepatitis virus. Were able to pivot and began to work on coronavirus, on COVID. And so that's been, I think, something that's been really important. And you're going to hear from Trevor Bedford, who was working in influenza, another very important virus, and was able to very quickly begin to look at COVID as well. So when we think about what kinds of things people at the Hutch have worked on with COVID, I'd say there's several lines of research. First is the idea of tracking, testing, and mapping the epidemic. His work as a molecular epidemiologist, a genomic epidemiologist, really one of the pioneers at understanding how this virus spread around the world, which is incredibly important. Second was the idea of thinking about, can we come up with treatments that could be effective? And many of our scientists at the Hutch and at University of Washington and at Seattle Children's and at the Brotman Beatty are working really hard to try to come up with treatments, either coming up with monoclonal antibodies that could possibly neutralize the virus, or even small molecules that could make a difference. And then finally, the idea of vaccines we think are incredibly important. And as I mentioned, the Hutch has always had this interest in HIV. We are the center of the HIV vaccine network, which is a global group of investigators working on vaccines, and under the direction of Larry Corey and Julie McElrath, who are senior scientists at the Hutch, we're going to be coordinating a lot of the vaccine studies globally for patients going forward for coronavirus. And I believe the first one looks like it will open in early July. So it's going to be a lot of work in prevention, and the vaccine is going to be absolutely critical, Mike, to getting people back to normal in our society as much as we can. I think one thing that's really struck me is the collaborative spirit of this town. I'm an East Coaster. I see your Boston Marathon jacket you've got on. I had the pleasure of running the Boston Marathon about 20 times. It's a phenomenal event, and it's a phenomenal city. I live my life between Boston and New York and New Haven, Connecticut. So coming to Seattle for me has been really a terrific experience. And I've been struck by the collaborative nature of the town, how government and companies and people work together, don't always agree. Like any great city, you're going to see a great diversity of opinion across the town, but a real sense of shared mission, I think, is something that we're very proud of. And at the Hutch, being involved in that response to COVID, I think has been very important at that point. I want to just tell you about one study that we're doing at the Hutch right now, which is the COVID Watch study that Julie McElrath and others are doing. Again, this has been sponsored by Amazon, helped a lot by philanthropy from Amazon at the Fred Hutch. And it's following people who are at high risk of exposure, physicians, nurses, police, firemen, first responders, to be able to, EMTs, to be able to look at how the immune system responds to the virus as we move forward, which is incredibly important. And then, Mike, I think, we talked a little bit in the beginning about the three challenges of confronting a virus and economic recession, and then understanding the social justice moment that we're in right now. I think as many of us, and we'll talk a little bit about this with Trevor and with Steve and Julie, is the idea that it's pretty clear that that people of color are at clear disadvantage in terms of greater incidence of the virus, and are suffering a much greater death rate from the virus. And ways that we can work as a society to address that in this moment of confronting racism is going to be incredibly important. It's something we take very seriously at the Hutch, and we look forward to being able to make some inroads into those areas as well.
Thank you, Tom. It's again, the work that you and your staff do, and all of the frontline people in this battle against COVID-19, we greatly appreciate it. Thanks for coming on and sharing some of your knowledge.
Great, thank you, Mike. So let's now we're going to have some discussion with some scientists from the Hutch, and I'm delighted to have Trevor, Steve, and Julie join me now. Trevor, I guess we'll start with the first question for you. Whenever I see you, I have a little bit of PTSD. You and Steve were the first two people that really made me understand what we were going to be facing. And I remember the first day that I met you was in a conference room at the Yale building here at the Hutch, and you came in and talked to us about what you were seeing in the spread of this virus in Washington State. It's been quite a roller coaster since then. And we know that the Seattle flu study has been changed into the COVID network and next strain. Tell me what you're doing. Tell me the kinds of things you're excited about now in terms of understanding the virus and viral spread.
Mm-hmm. Thank you, Tom. So from January, I've been watching the genomes appear and trying to kind of make sense of things. And so in early January, there were SARS-CoV-2, the virus that causes COVID, genomes posted publicly to from scientists in China and in Thailand. And then early on, we could really see that there was human-to-human spread. And that was kind of this first signature. And so spent lots of January trying to kind of convince people of the threat here. And then after that point, as more data came in, was really through nextstrain.org, trying to track how the virus is spreading throughout the world, and when you have kind of these ignition of community spread in different areas. And so all of that kind of tracking has been going on at this global scale. Then more locally, there was the Seattle flu study that we got going back in the fall of 2018, that was meant to diagnose and sequence flu infections in the Seattle area. And so we had an apparatus to collect lots of samples, diagnose them for different diseases, different respiratory diseases, and sequence them. And so it was that surveillance apparatus that we're able to use to, before kind of anyone else had their act together, really be able to find early infections of of COVID and then do that sequencing. And so this happened at the end of February, the beginning of March, and really kind of showed the extent of community transmission that existed in Seattle at that time. And since then, we've kind of basically been on the next-strain side trying to kind of make this a really robust platform for doing this genomic epidemiology, both with us and getting the same software in use by public health throughout the world. And then also having the Seattle Flu Study has become SCAN, Seattle Coronavirus Assessment Network, to be able to have this very kind of rigorous assessment of prevalence in the Seattle area across different ages, demographics, geography, et cetera.
So Trevor, I guess one question I have is New York Times this morning came out with an article that talked about a new mutation that's been found in COVID that may stabilize the spike protein and might possibly make the virus more pathogenic. What's your take on that? And again, this has been mostly in a preclinical modeling that they've been studying this. Does it have clinical relevance? Tell us a little bit about that.
Yeah. So there's always this question, and it's surprisingly difficult to actually address. Of if you see a mutation, what effect does it actually have? So we've been paying attention to this mutation in spike protein, which is what actually binds the human ACE2 receptor. So we know it should be important. There's this D614G mutation that we noticed back in February and kind of had shared with people doing vaccine research at the time. And subsequently, that mutation has seemed to overtake its kind of ancestral variant. And so we've seen that that it start early on in the, say, the US epidemic, most things were this D variant, but over time, things have mostly become this G variant. And this could well be because that it's there's some transmission advantage to this mutation. What's been difficult is that mutation happened to coincide with the first transmission chain that arrived into Europe through Italy back in early February. And so it can be that this G variant really has been being really successful due to epidemiology rather than due to a kind of a fundamental phenotypic difference. However, we're starting to see, and so that was kind of the first observation. You see a small change in viral titer and viral load between the two variants in clinical samples, but it's not huge. To my knowledge, no one's been able to see a difference in outcomes between the two different variants. But then I've seen there have been recent preprints appearing like this and the study that you're referencing that are showing some kind of lab assays that are showing phenotypic differences between the two. And so now we're left like not even quite sure what's going on. It very well could be a thing, but it's not. I'm not completely convinced that it's really driving this transmission difference.
And Trevor, and then yesterday we also saw that the stock market plummeted because people felt that there became emerging evidence that we may be dealing with the very beginning of a second peak at this point. What's your take on that from an epidemiologic standpoint?
Yeah.
Not on the market part, on the peak part.
So what we've seen is that in the last 2 weeks, there's been a steady uptick in confirmed cases in a number of states. I think it was 14-ish, and that has kind of correlated with reopening strategies, but not perfectly. There are other states that have reopened, like Georgia, that we don't see this happening. Generally, there's a huge amount of stochasticity in what's happening. It seems to be kind of, you get a kind of a spark that lands and then starts to take off and so on. But this does look like the kind of current social climate and human activity patterns in some number of states have ticked up. Everything had been on the downturn and had been coming down, and there are now some geographies where the way that humans are behaving and the amount that the virus has caught on has kind of started to allow it to tick back up. I think what happens going forward will depend again on how people behave. So in these areas, if people get worried about current continued transmission and then kind of behave a bit more carefully again, then we could actually see that easily come back down. Or people could kind of continue, just try to push through and then not worry about it quite as much. And then we'd expect to see cases continue rising. And I think this has been what's been fundamentally challenging for me to understand or to even make any predictions of what's going on. Is it's not so much about the virus. We know what the virus is going to do in a given circumstance. It's that how people behave varies hugely. And I definitely didn't expect kind of coming into things how much kind of thought people would have for their neighbors in doing this kind of, we've rearranged the world to be able to protect each other. And I had initially back in February thought it was going to be just much more of a massive flu season. People would tolerate lots of death around the country and go about their lives. But that definitely hasn't been what's happened.
Yeah. So Trevor, thank you very much. Next, I want to ask a question to Steve Pergam. And Steve, as a clinician, Steve runs our infection control program at the Fred Hutch and the Seattle Cancer Care Alliance and the University of Washington cancer program. And Steve, you've put a lot of effort into infection control and making things safer for patients. What do you think that the advice you've given to hospitals and clinics has made the most difference to make our hospitals and our cancer programs safer?
Yeah, thanks, Tom, and thanks to everyone for listening into this. I think there's probably no one particular thing. I think it's a combination of a lot of different activities. So from a lot of different perspectives, we are doing a lot more testing. So we're out on the front line identifying people who are coming in the door and really trying to identify people with symptoms that we can test appropriately. Additionally, we're doing a lot more testing in the community. So before patients come in, we're doing phone calls ahead of time to bring them in and assess them prior to entering into the facility. We've also changed how we approach prevention. So in the past, it would always be we would put people in isolation, have them wear masks and gowns and gloves, et cetera, when patients were presenting with active symptoms. And we've switched our approaches. It's really been a fundamental shift nationally in hospitals where everyone's masking all the time with every interaction. And everyone who enters into the facility now wears a mask, either if you're a provider, a patient, or a caregiver, or a loved one. So that's been a fundamental shift as well. And so each of these things, and there's more to just those, but each of these are different shifts that I think play important roles. And I think you can think about it. It's kind of what's happening on a city level and on a national level is that hospitals have had to take these and sort of amp them up a little bit higher within these institutions to make sure that we can prevent transmission events. Because when you have a lot of sick people together, there's a potential risk for clustering, and when an individual case can happen, you can have lots of spread around. And you've seen that in some of the high-risk areas like some of the nursing homes and long-term care facilities in both the region and nationally. So I think there's a lot of different activities, and it's a huge amount of work, a huge amount of people who put effort into prevention. It's not just sort of me and my colleagues who work in infection prevention, but it's really institutional support, both from my colleagues and Fred Hutch and people like you and leadership at the Seattle Cancer Care Alliance, who have really sort of said, not only are we going to do the work, but we're going to put resources behind this, and we're going to focus on saving lives and prevention first and worry about consequences later. I think those have all been really critical pieces.
And so, Steve, one thing I'd like to follow up with you on is a question that I was just talking to Trevor about, which is the current epidemiology. And Trevor noted that there's been this increase in number of cases. And just for the remainder of you who are listening, one of the things I ask Steve pretty much every day that I talk to him, cases were up last night. What does that mean? And Steve always tells me, Tom, don't look at cases because it might reflect testing differences. How much of this could be the fact that it's actually easier to be tested now, and we're testing more versus the virus is spreading more?
Yeah, I mean, it's always a question that comes up. I think in Washington, as an example, the governor just put out a notification today that said that anybody who wants to be tested can be tested. We've seen this recently with what Mayor Jenny Durkin did, where she said if you've been involved in the protests, you can go to a number of different sites and get tested. There's a lot of work within Washington State and with Seattle to make testing increasingly available. initially in the early phases of disease, we really advocated that if you were otherwise healthy and you had mild symptoms, not to come in to get tested. And that's really been a game shift. As we've said, we want to identify more of these people because we want to be able to not only identify them, but do contact tracing and test those around them. And so you're seeing more asymptomatic testing. You're seeing more mild symptom people getting tested. And so I think that's maybe some of it in some places. So I think you have to keep that in perspective a little bit. But I think in other states, the testing is not really as robust. So I think it really depends on where you are. And that's one of the difficulties in sort of addressing sort of the national experience, is that the resources and how they've been allocated, the ability of particular states to have, the tools and the testing supplies has really varied. So we were really lucky, as you know, in the state of Washington to have our colleagues at UW Virology and one of our faculty members who worked on testing and had it. We were one of the first labs in the entire United States that had PCR testing available. And so we have been much more on the forefront of doing lots more testing in other sites. So it may be somewhat related to that, but the other thing to keep in mind is testing is only one piece of it. The other piece is that people are often looking at the numbers now and saying, well, what's happening now? And I actually remind you that what you're seeing is actually a couple of weeks prior. So, whatever's happening now probably is a reflection of what happened a few weeks ago. So if you go back, it was probably closer to what was happening around Memorial Day and maybe some of the effects of Memorial Day and seeing some of those changes now. So it's always a couple of weeks behind. So if you're trying to sort of plan what's happening, it really is important to focus on what you're doing today is actually more important for kind of 2 to 3 weeks from now, rather than what is happening tomorrow. And so just those day-to-day numbers, you always want to be a little careful. It's really about trends and how things change over time, which I think has been more important in terms of the way I've looked at things. And I think I've learned a lot of that from Trevor in terms of thinking about, prognosticating for the future.
Great, Steve, thank you. Next,
Sure.
I'd like to bring on Julie Overbaugh. Julie, in addition to being a prominent researcher in the HIV field, Julie also runs our education and training programs at the Fred Hutch, and has trained countless students, PhD students, college students, medical students, high school students, and really showed them and shared with them the power of science to make a difference, and really done an incredible work in that area, in addition to what she's done in HIV. And so, Julie, you've been in the viral field, the HIV field, since the 80s. What's similar to HIV in the 80s and COVID now, and what's different?
Thanks, Tom, for that question. I've actually been thinking about this a lot because I did start working on HIV/AIDS in the 80s, and there's so many parallels right now between the 80s and the HIV response, the pandemic itself. For example, in the mid-80s, we developed a diagnostic to detect HIV, just like we have now for the coronavirus, the novel coronavirus. The pandemic was spreading in over 50 countries, very much like what we're seeing now. At that time, the deaths were in the tens of thousands, not the millions, for HIV. And so I kind of think of the 80s and HIV as a bit like early spring in the coronavirus pandemic. I also see parallels in that there was a very disorganized response to HIV, where we lost valuable time in curbing that pandemic, which I think we're also seeing with the coronavirus. And while the resource-rich countries were trying to find a path to slow the spread of HIV, new infections were just raging under the radar in resource-limited countries, particularly in Africa, which I fear might be true for SARS-CoV-2 in 2020 as well. And so if you fast forward now, we've had over 30 million deaths from HIV, and we have over 30 million people infected with HIV currently, and much of that is in the global south and in Africa. And so that is a rather sobering perspective when you think of it that way. I think the positive is we do have good treatments for HIV. We have treatments antivirals that can treat people who are infected and suppress their virus so they can stay healthy. We also have treatments that can be used to prevent new infections, but we are 40 years out and we do not have an effective vaccine. But turning the coin the other way and sort of moving away from maybe this more sobering perspective on what happened with the HIV pandemic from the 80s to now, I do think we're much better poised to respond to this pandemic. We've learned a lot from HIV. We've learned methods, we've learned immunology, we've learned ways to attack the virus that are gonna, I think, feed right into what we do with this new pandemic. You know, for example, and Steve just mentioned the diagnostic capability and how rapidly we deployed that here. I think that was directly related to how we developed HIV diagnostics and diagnostics for other viruses, so that we were able to take those platforms, those approaches, and very quickly turn them around to detect the new virus. And that saved us critical time that we didn't have with HIV. Another example perhaps is that we have studied antibodies a lot in the HIV field because we think they're important for vaccines. We think they are for the novel coronavirus as well, because they are thought to be associated with protection for other vaccines. For HIV, it took us years to decades to be able to isolate and characterize those antibodies. But because those technologies were in hand, we see now people are doing that within weeks to months for the new coronavirus. So that technology has directly translated to being able to study this virus in a much more rapid turnaround. And of course, Tom, you mentioned the vaccine trials and the infrastructure. I think the trial structures that we have in place for HIV are going to be enormously important. I think the vaccine platforms we've developed are going to be important because we've developed ways to provide antibodies, to deliver antibodies, and they've been tested for HIV, and I think are again going to translate quite nicely to the new virus.
And Julie, do you think we'll have a vaccine by the end of the year, by the end of 21? I know it's unfair to ask, but a lot of the people who are watching this are really curious what your thoughts are about it.
Right. You know, I wouldn't bet anything on any particular outcome at this point. You know, having been in the HIV field and seen promises of vaccines, and then realizing there were just things about the virus that we didn't think were as hard to solve as they are. And you know, I think again, the advantage we have here is this virus. We know a lot more about just vaccines in general. I think this virus at least appears to have some more straightforward aspects, but again, we were fooled by HIV. So I would not bet on that. And I think what may happen with vaccines is we might get some that work a little, and that would be a start. And maybe that will come first, and then we'll improve on them and we'll make them better.
Okay, great. Well, I want to thank you. And also, we've been getting a lot of questions have been sent in advance by employees at Amazon. So we'd like to start to try to answer some of them. And I'd like to ask Steve Pergham to come back for a second to address this question, which is, Steve, let's talk about questions about how people can stay healthy. And Steve, you've been a big proponent of wearing a mask and the importance of masking in public. What's your advice now on where we stand with mask use?
Yeah, sorry, Tom. For some reason, my video is not turning on here. Hold on a second.
We can
not sure why.
See you perfectly, which is great.
Oh, you can? Okay, great. Okay, thanks. I just can't see myself, so that's fine. So what can you do yourself, and what are ways you can protect yourself? Well, I think I sort of put this in the structure of, I think we need to start thinking about not just protecting ourselves, but protecting our community. It needs to be sort of a double-edged sword. I think we need to really be focusing on what we can do for ourselves and our families, as well as talking about what we can do to prevent transmission in our communities. And so I think, you know, for a lot of people, there's a sense that, you know, if I go out and I'm outdoors, I'm going into a restaurant, I'm going into a place of business, you know, wearing a mask is not really that important. I would argue it's very important. And so what we know with the virus is the virus can be transmitted through an asymptomatic period prior to development of symptoms. So you may be asymptomatic and walking around in a place of business, but you actually can be potentially spreading this virus to others.
Steve, just stop for 1 second on this, because this is controversial. We've heard from the WHO that asymptomatic spread is rare.
Yeah, so they've walked that back. So the way that I would caveat their description, I think it was a a misstep in terms of how they characterize this. I think there's really two groups who you can bucket together as asymptomatic. There are truly people who never develop symptoms who have virus detectable. And you really, ask them deep questions. Do you have any symptoms, et cetera? They may have none. What's more likely is that people have an asymptomatic phase before they develop symptoms. So they don't realize they're ill, they go out into communities, and then they spread. And so if you look at data from Iceland as an example, where they tested the entire population and found people that were positive that had few symptoms, the majority of them went on to develop symptoms later. It's a slight difference in terms of how you describe that. So we actually think that asymptomatic period, that pre-symptomatic phase, is really important in terms of transmission. So I think the asymptomatic group is a much smaller group, and I think probably doesn't drive the majority of those infections, but asymptomatic transmission does. So it's kind of, you have to be careful about the nuances there.
Okay.
So I think that if you're pre-symptomatic, let's use that term, and you're infected but you don't know it, and you're out in the community, you can transmit to others. So wearing a mask when you're breathing and sort of interacting in close contact with people, you can potentially transmit viral particles through that way. And so by wearing a mask, you decrease that transmission. We don't know exactly how much, but some have made estimates that it can decrease it by 50%. And if that's true, it's a huge amount. So when you're wearing a mask, you've heard me say this many times, Tom, is that masking is not always about you. It probably provides less protection from you getting it from somebody else. But for everyone, if we're wearing masks, we're preventing asymptomatic transmission from ourselves to others. And so by wearing my mask, I'm protecting you. And by you wearing your mask, you're protecting me. So I think that's one really important piece. The other is washing our hands on a regular basis. If you're touching surfaces when you're out in the community, washing your hands is really important. And using hand gel or a sink with soap and water are really important. These seem like basics, but they're critical in terms of prevention. And then finally, social distancing, and I think many of us prefer the term physical distancing at this point, are important. It still remains important. Masking and washing your hands are two components, but they don't sort of help as much as physical distancing does. So remaining as much as you can from having to spend time with people in public places is critical. And however we can do that, I think is an important piece to maintaining the levels of preventing transmission. So particularly for those who have household members that are older or higher risk for complications, I definitely advocate continuing to sort of as much social distancing as possible.
Okay. Trevor, question for you. Earlier we talked a little bit about mutations and how you've been following them, and you mentioned that we've been seeing a slight increase in cases. When Steve Pergam and I have been talking, Steve has talked about that we might find two patterns. One pattern could be that the virus just sort of stays there for months and months and months and months at kind of the level it is now. The other is that we see these peaks. What do you think about a second peak? And when do you think, if we have a second peak, when are we most likely to see that?
Mm-hmm. So, yeah, it's a good question. I think that generally, as I was kind of saying before, that really this is dictated by how people will decide to behave. There's a bit of a definite effect of seasonality, and we see this with coronaviruses in general, where they're kind of winter respiratory diseases. But generally, that seasonal effect is fairly weak. And so I would expect that most of the differences that we're seeing is how people are behaving. And so I think that what we're going to expect is much more kind of a patchwork, which is Ed Yong's term for it, which I really like, where we have different states that end up behaving differently and end up having kind of a different epidemic than others. And we could well have some states that have kind of a bit of an epidemic resurgence. Then there's kind of a round of people being more socially distant, and then kind of things come back down, and you have a whole different kind of anti-phase behavior in some other states. I do think that come fall, once we don't have seasonality on our side and there's kind of more fatigue in terms of physical social distancing fatigue, that there's kind of more of a risk of a general resurgence.
Okay. And Trevor, tell us about the protests. We know we've had a lot of people who've been protesting and showing support for anti-racism movements. thoughts about the impact that that could have on spread?
Mm-hmm. So the folks in Japan have basically focused and done a really good job controlling their epidemic, focusing on the 3 C's, on closed places, crowded places, and close spaces. And that if you look at, like, Ben Cowling had a really nice contact tracing study out of Hong Kong that was just published, where you see that 80% of the cases, 80% of onward infections came from 20% of the infections, and these were mostly vectored in nightclubs, crowded bars, these sorts of situations. And so you see that this has a big effect. The protests are in some, not in all cases, in some cases they are close and crowded, but they're not enclosed. So being outdoors has to help a lot. We see a really good adherence to wearing masks, which is excellent to see. We're still likely to expect some additional infections that result from people attending protests. I think generally when you think about this, you have to kind of think about what activities society views as essential activities. We, during all of March, et cetera, we didn't say you can't go get food at the grocery store. And so protesting for fundamental human dignity and racial equality is something that I would think of as an essential activity for our society. Generally, these additional cases, additional infections that you could spark at these protests, how I view that is that the best thing that we should be doing generally as society is making it so that if you have cases of coronavirus, that those kind of tend to maybe infect one person or half a person and they kind of trickle out, and that by having strong public health response of test, trace, isolate, along with general infection control on society at large, you can kind of keep things from spiraling out of control. And so then by adding some additional infections via the protests, that kind of adds a few, but it doesn't kind of add additional large transmission chains.
Okay, I'm going to ask you one question before I'm going to turn to Julie. Question is, we've talked again about mutations. Some people have questioned, this actually came in from one of the Amazon employees, whether the mutation rate could make a vaccine less effective. Much the way that we find that each year we have to get a different vaccine for influenza.
Mm-hmm. Yeah, it's a good question. So we see first, just on the thinking about mutation rate, that that SARS-CoV-2 has a genome of 30,000 bases, as opposed to a flu genome of 13,000 bases. It mutates about half the rate of flu per base, but it ends up being roughly pretty similar rates over the entire genome. But what's important for the vaccine is going to be kind of the sites where the actual, if you mutate them, you might stop an antibody from binding. There, what ends up happening if you look across other viruses is it's not the raw mutation rate that matters, it's how kind of robust that protein is able to mutate, how evolvable that protein is so it can mutate while still escaping from antibodies. So as kind of a corollary here, if we look at measles virus, it mutates just as fast as SARS-CoV-2, but the vaccine from 1950 still works today because the parts of the protein that antibodies target can't mutate while still maintaining their function. So you see that kind of bit of the protein that's very stable. Whereas for flu, the bits of the protein that are targeted by antibodies are quite flexible and are able to escape from immunity. And so I think it's much more about kind of these protein aspects rather than about the raw mutation rate. If you look at seasonal coronaviruses, there's some evidence, or we have a research project on this, there's some evidence that you actually do have antigenic drift, that you do have kind of mutations in these antibody binding regions, et cetera. It's unclear whether that will extrapolate to SARS-CoV-2. If it does, I expect that it will be on the kind of multiple year timescale. So it'll look like influenza, where we have to update a vaccine every 2 or 3 years, rather than it kind of making a vaccine itself be impossible.
Okay. Okay, and I know that you're devoting a lot of your career to understanding how we can come up with universal ways of treating flu and preventing influenza as well. I'd next like to ask a couple questions to Julie. So Julie, tell us a little bit about what it means to have an antibody test that's positive. I know a lot of the people from Amazon who are watching this are thinking about, should I get an antibody test? What does it mean to get an antibody test? And if I have an antibody, does it mean I'm protected?
Yeah, I think that's a very timely question, Tom, because we now have good antibody tests for this virus. We have some that aren't so good, but there's good ones out there. And you do hear people talk about, the idea that they want a positive antibody test because they're hoping that means they're immune to subsequent infections and they're done with this. And so what I will say is we don't know that. And maybe I should just step back and tell you, in a few words, why we care about antibodies. Well, I mentioned before that there's sort of what we think is important for all vaccines against viruses. And they actually can attack the virus, bind to the virus, and prevent it from getting into another cell, which is how it makes more of itself. And so that's a way to break the cycle of virus replication. And they also, antibodies can also kill the cells that are infected directly. So it makes sense that we think antibodies are going to be powerful tools against viral infection. In the case of the coronavirus infection, we know they're elicited a little bit after the virus really peaks, and that's typical of most infections. So you might see somebody who's symptomatic start to show detectable antibody levels about a week or so after their symptoms. And usually when you detect antibodies, it's actually because the infection is waning, or it's an indication you had a past infection that's over. And then these antibodies can stick around for months or even years. So the big question is, will they protect from infection? If you have these antibodies, will you be protected against subsequent infection? And we don't know that. And I think the things we need to know is how much of antibody is needed, how much do we need of what type, are they the kind that kill cells, or are they the kind that block the virus from getting into cells? Do we need both? And how long will they last? And I think you also talked a little bit with Trevor about the question of whether they'll be able to keep up with the virus as it mutates. So there's a lot of important questions that we still haven't sorted out. And again, returning to the HIV setting, I think we assumed for many years that people who are HIV positive would actually be protected from getting reinfected. And our work actually showed that that's not true, that it gives you about a 50% protection, but it doesn't really fully protect from getting reinfected with HIV. And we'll know that with this virus as time passes, but we don't know it now.
Okay. And Julie, one question that, one of the people from Amazon asked, which I think is a good one. We know that in this country and actually globally, there's a pretty big anti-vaxxer movement and people who are against vaccines. Generally, the arguments that have been raised are that there are side effects we don't understand. The trials are rushed into patients, and that there's an unholy relationship between the vaccine makers and the governments that support vaccine recommendations. Right now, we are going at warp speed. In fact, we're calling it warp speed as our way of getting vaccines to patients. And clearly, I very much hope we're able to do that. What would you say to an anti-vaxxer who's worried that we're rushing the vaccine and therefore there might be side effects that we don't see?
Again, a good question, Tom. I think I just want to say, of course, that licensed vaccines are generally safe. A lot of the information about vaccine side effects was, of course, incorrect, and we know that now, and that was corrected, which is not to say that there isn't some risk with vaccines. What we think about is, what's the benefit? Could we save lives? How many lives could we save? And what side effects might be associated with those benefits? It's not a yes or no answer. So I think that's important to keep in mind. And also, the process of developing vaccines and testing them are pretty well laid out. I think we've developed good structures for these. We start by doing what are called phase 1 trials, which are trials only to ask if the vaccine is safe. These are not about understanding whether the vaccine works, but first and foremost, in a small number of volunteers, do we see any unexpected effects? At the same time, people are doing studies in animal models, including non-human primates, to look for whether or not there's any side effects, whether there's an immune response. So these things kind of go hand in hand. And in the case of this particular virus, one of the things that's perhaps on our side is that there were two highly related viral outbreaks of coronaviruses, one called SARS, the original SARS, and another one called MERS, and they're closely related to this new virus, SARS-2. And they've been tested in clinical trials, vaccines against those viruses. So we actually know a little bit about how that worked, and these are very closely related viruses. So there's some predictability, I think, for what might translate there. But certainly the early vaccine rollout, if they look safe in phase 1 and then phase 2, which is also a safety and efficacy, do they look like they're giving some kind of immune response sort of to the vaccine? And then the phase 3, which is where we really ask, are they effective? We'll know a little bit about side effects from those, and we'll know if there's any really significant side effects, I think, that are common. But it will take vaccinating more people to see if there are rare side effects and more exposure to the vaccine. And I think that's certainly true just as you roll out vaccines.
And Julie, you mentioned SARS and MERS, which happened outside the U.S. And I know you've had about a 25-year relationship with HIV researchers in Kenya, and do appreciate the importance of a global response from an infectious disease standpoint. Can you comment a little bit about the global nature of this pandemic?
Yeah, as I said in the beginning, I worry that there's parallels with HIV, where there was this kind of smoldering high level of spread that was occurring in the global south that we just weren't detecting because we weren't ramped up to do that. I think we're in a better position now because many of us, including myself and others at the Hutch, have very close long-term collaborations in Africa. And we've trained PhD students here from, for example, Kenya and Uganda, and they've gone back to their countries as trained molecular virologists, able to lead efforts to implement diagnostics, set up laboratories, et cetera. So there's much better capacity, there's much better infrastructure. But even in our own efforts to set up capacity in Kenya, just getting simple things like a hood that would protect the staff while they use samples, took us months to do. It's a very complex process. We have people who've worked with us for 20 years there, so it made it a lot easier, and these collaborations make it a lot easier to try to be of assistance. But I think we don't really know what's going on in much of Africa.
Well, and Julie's keeping with the global theme, I'd like to ask Trevor a question now about NextStrain. And Trevor, NextStrain is a collaboration that you have with some scientists in Switzerland. Tell us a little bit about that collaboration. How that's helping you in tracking COVID.
So the nextstrain.org came out of nextflu.org, which the whole history was a kind of a prototype that I had made back in the summer of 2014. I had put that up online and kind of hadn't actually to look at flu evolution, hadn't really been touching things. Richard Nair from now at Switzerland, University of Basel, picked that up and kind of ran with it and added continued development. And then we brought that together and then kind of have been working on things since early 2015, first with flu and then Ebola and kind of a variety of other things. And what's been, and that kind of collaboration has been really excellent. What we've been doing now is really trying to we can't do this tracking for the world. And basically, we're trying to get the software spun up for a number of different labs and groups, academic labs, as well as public health institutions from across the world, so they can kind of do the same sorts of things with their sequence data. And so the current focus has been a little less on kind of primary research and more on this kind of community and tool building and that kind of platform building, which has also felt really gratifying.
And so, Trevor, Amazon and AWS have top tier machine learning experts and artificial intelligence capacity. How can that help?
Mm-hmm. So I think there are scientifically kind of two big directions here. One continues to be on the epi side. Right now, there's a lot you can do with the genomic data, but there's kind of a fundamental limitation to how much information it provides, where the virus is mutating on average about every 2 weeks or so. And so you'll get these whole clusters that have completely identical genomes just because there hasn't happened to be a mutation between them. And so just from the genomics, you can't really tell what's going on in that case. And then you want to be able to bring in other epi data, contact tracing data. You can imagine Bluetooth proximity data if the apps get uptake, where you could actually use this to really understand transmission. And then on the other side is going to be connecting in kind of clinical data with viral genomics, where if you have kind of big EMR databases and so forth, you could actually learn about that this genetic variant of the virus has this associated clinical manifestation. And that's a kind of very significant machine learning problem as well. And so kind of different, I think of those as kind of different bits of metadata, where the epi side is much more kind of person, place, and time and traditional epidemiology, and the clinical side has all of these different clinical outcomes associated with things. But both are, in many ways, fundamentally machine learning problems.
Great. And Steve, I'd like to ask Steve Pergam to come back for a couple of clinical questions. So Steve, one of the questions that I have is there was a piece in the New York Times today about people who've had symptoms of COVID-19 for 60 plus days. As a physician taking care of patients, to me, that seems like one heck of a viral syndrome. How do you explain that, and what does that make you think of?
Yeah, it makes me think of West Nile virus, actually, as a good example, where I think initially with West Nile, we saw these patients get primary infection. That's actually part of the reason I got interested in infectious disease. It was during an outbreak in New Mexico. We were seeing patients who, after primary infection, were having these ongoing symptoms for months on end, some even up to a year, where they were profoundly affected. They weren't necessarily people who developed severe symptoms initially, but this sort of prolonged fatigue and other complications were really dramatic, and it wasn't clear why. So I think some of that is related to novel viruses that our bodies have not seen before, have led to changes that can reset the immune system in a different way that causes maybe prolonged inflammation. Maybe it leads to changes in fundamental biology that change how people react. It's probably variant, because we see some people get sick and respond really quickly. We see young people get illnesses that are quite profound. So I think part of what will be really interesting as we move forward is trying to understand the genomics and what are the differences between the host as well as the virus. So there may be differences in who people are, and then the genetic breakdown and the genetic components of who they are that may help to better understand who develops more complicated symptoms, who goes on to develop chronic progressive symptoms, and who goes on to develop really severe disease. Because we've seen variances across the country. We've seen people in their 80s who do fine, and people who are in their 30s who do really poorly. So generally, it's the older group that does worse, but it's probably a little bit of a difference. So I think it's these post-viral complications that happen are probably more frequent, and I think we just recognize them more clearly in really novel strains because of the profound immune response that happens when something is you've never been exposed to in the past.
And Steve, I'm going to ask you an important question now, because if you think about where we are as a society and the social justice concerns that we're looking at, when you look at the outcome and the burden that COVID has put on people of color in the United States and even Black people particularly, why is that, and what can we do about it?
Yeah, I mean, there's probably lots of reasons here. I mean, unfortunately, a lot of the African-American community and a lot of people of color are in positions and jobs that really require them, just because of social inequity, are in positions where they have to go to work every day. And so they don't have the capacity like me, where I can sit at home in my household and be protected. I have the ability to work from home. I have a job that allows me to do this through my computer as much as I want, and many of them are having to go to jobs where they're put at risk every day. If you look at nursing homes, a lot of the people who are working in nursing homes as medical assistants, et cetera, are people who are new immigrants from around the world who are looking for their first job. And this is a great way for them to get into this, but it also puts them at high risk because they have to be there. You also see in certain groups that they often live together in more closer family organizations. So in the Latino community, they're often more common to live in households together with multi-generational families. And so I think that also plays a role in how that's developing. So if you look at places like the meatpacking industry in the Midwest, many of the workers there are a Latino population, and they've continue to work through this process. Or in Yakima with the people who are picking fruit and working in those areas, you see those are populations that really need to work to continue to do that. And so you're seeing a higher burden of disease in those locations. So I think a great example is New York City, where Manhattan had cases, but not quite as dense as places like Brooklyn and others where there was more people of color that were working in jobs that they really couldn't take time away. So I think there's the social inequity between in sort of how we look at this has actually really come to the forefront and is a high level. And I think we're seeing it in the way it's playing out in the virus. And so I think one of the reasons that I've sort of been supportive of a lot of the protests and others is similar to kind of what Trevor said, is I think this is a fundamental reason why we're seeing differences in the number of cases that we're seeing in these populations. And I think it's a critical piece that we can't underestimate.
Steve, thank you. And I want to finish now with a question for Julie. This will be our last question because we're at time. So Julie, how is the Hutch anticipating future pandemics? And how do we know we're not going to be in this situation with a different virus in 3 years?
Tom, I think it's never more apparent that the scientific workforce is important than it is now, and maybe particularly virologists and immunologists. And I think the Hutch has been at the forefront of training virologists, and we're particularly strong in that area. And I think we've seeded a lot of virology at other institutions, which is great. In my scientific lifetime, which I'm not that old, we've seen many pandemics, HIV, we've seen the 2 other coronaviruses that I mentioned, flu, Zika, Ebola. This isn't going to be the end. We're going to see these kind of outbreaks with novel emerging viruses to come. And so I think that training the next generation of scientists is critical. We have a great training program at the Hutch in viral diseases and viral evolution. Some of my own trainees have been at the forefront on this. The first one diagnosed the first case of coronavirus in Michigan. Another helped set up the infrastructure at Stanford to actually start working on this virus at warp speed. And so I think it's important that we continue to emphasize training. And I think it's very important that we emphasize training, including individuals and scientists in resource-poor settings, because these diseases are global. So I'd like to see that that's something that people appreciate more from all the devastation we're experiencing for this outbreak.
Julie, thank you very much. And so to close, I want to thank the Amazon employees for their questions. I want to thank Amazon for their partnership, and I want to thank the thousands, hundreds of thousands of Amazon employees who've helped all of us get through this, through the work that you do to bring needed food and supplies to us around the world. It's incredibly appreciated and noted. Mike, I want to thank you for everything you've done in support of the Hutch, in support of science at the Hutch. Thanks for welcoming us, and thanks for including us in this Fishbowl program.
Hey, Tom, thank you so much for being here. And Julie and Trevor and Steve, it's been so insightful and helpful for us to get a good understanding of COVID-19. So we greatly appreciate that. I also want to just express again how appreciative we all are of you on the front line, our healthcare workers doing the really hard work of protecting our communities, and just appreciate all you're doing there. So thank you and your team for that. And by the way, everyone, if you'd like to get updates on the research from the Hutch, The website is Fred Hutch, FredHutch.org. So feel free to hit the website and get updates. And if you want to help the Hutch, one of the great things we do every year at Amazon is we participate in an event that the Hutch puts on called Obliteride. And Obliteride is a biking event or a walking event. And over each of the last 7 years, we've participated in it as Team Amazon. And you can as well. Just go out to obliteride.org. That's obliteride.org. You can sign up as part of the Amazon team. It's a fun bike ride, a walk. You can run to raise funds for the Fred Hutch. This year, the event's going to be virtual, as you might imagine. So anyone around the world can participate. By the way, over the last few years, we've had global participation. Pick any event you want, set a goal, and finish by Saturday, August 8th. My family and I are going to do it. I'll do it for the 4th time, the 100-mile bike ride. 50% of the funds will go to COVID-19 research, 50% to cancer. Last year was the biggest Amazon turnout ever, and the team raised $71,000. Let's see if we can even do better this year. Again, go to obliteride.org. Thanks, everyone, for participating today.